Well, thank you very much for that lovely introduction. Thank you, Professor Antonio, for inviting me up here. And I'm conscious that we've had a cognitive overload all day today. So my job is for you to relax, wind down. We're going to play some video games before dinner, okay? So chill out. This is going to be a data light project presentation, so you can just relax. So basically, at the moment, we've got 3 robots on the system. We've got the Monarch robot, the Ion and Galaxy. They've been around for about 5 years, believe it or not, but the amount of data we're accumulating is increasing at the moment. They all work on similar principles. If your son is an Xbox expert, then they should go for the Monarch. If they are PlayStation, perhaps the Galaxy. And if you're old like me, maybe the intuitive one, where it's a little bit more, excuse the pun, intuitive. They all have slightly different characteristics. Monarch and Galaxy works on electromagnetic navigation, and that's got its own problems because you get deflection of magnetic fields and it's more vulnerable to errors. The Philips and the Ion system uses the Philips shape sensing system, which is probably a little bit more accurate. So it's basically, like I said, a video game. The first process is you take your CT scan, you map it onto the platform, and you essentially tell the system, this is the right lobe of the lung, this is the left lobe of the lung. And once you've done that, you then go to about 70% of the depth of the lung. And what you will see is you can go so deep into the lung, this is generation after generation after generation, and still have a very good visual image of the subsegmental anatomy. So you basically go into the right lower lobe, you then go into the right upper lobe, left lower lobe, and once you've been through all of these areas, the system has mapped out what it has seen on the CT to what you have in the person. So and this is real time. So it takes about 1.5 minutes to do this part of the process. And once the system's mapped out exactly where you are, we then move to the navigation phase, which is this phase. So like every good GPS system in the car, you basically follow the blue line. And it's easier than someone else telling you where to go. So you essentially map out where you are. The system now knows where it is, and you just use the controls. The left-hand control just moves forward and back. The right-hand control moves 360, and you can virtually go to any part of the lung that you like. This allows you to sometimes synchronize the 2 images. So sometimes the system does kind of have a delay, and you can kind of go 1 step forward just to know what route you're taking, and then you synchronize it and then progress forward. And like any good video game, when you're at the right spot, you get a green ball, don't you, Benji? So there you go. So you can come and play with me later on. So once you're at that lesion, so this is a case that I'd like to show you. This is actually a 37-year-old gentleman, and he's got this ground glass nodule, and he's got other ground glass nodules, and it's got a slightly solid component on this one. You can see that there are a couple of solid components there on this one. So I said to him, well, we've got the robot. You've been scanned for like 4 years now, and my colleague says, well, it's nothing, just stop scanning him. But for the robot now, it's 7 by 8 by 8 millimeters. Should we biopsy it? So this was his procedure. I'll show you an abbreviated version. So again, like I showed you, just to explain it once more, you orientate the system. Once you orientate the system, this is obviously in a quicker motion. It maps out the whole thing. Once it's mapped out, you then get your navigation. And remember, that lesion is close to the pleura. So you can literally go with this robot to the edge of the lung. So you systematically just keep following the blue line, and providing you behave and don't go choosing your own route, you're going to be fine. So it goes right to the edge of the lung, and when we're at the right spot, we do a cone beam CT scan, which takes 5 seconds, and in 5 seconds we have the truth data. And the truth data in this patient, you'll see, is that we're absolutely at the nodule. And then we can take a biopsy. We tend to use radial ultrasound as well, because remember, the cone beam CT is near-time imaging, but the radial ultrasound is real-time imaging. You can see the radial ultrasound signal, and then we can put whatever tool we want and take a biopsy. So remember, this is 7 millimeter nodule, and at the edge of the lung, and we can access it. And this young man had an adenocarcinoma, which was the EGFR G112 variant. So he would have just been followed up for years. That could have been metastatic, and he could have a worse prognosis. And in fact, we then found out that his mother also had a lung cancer. We managed to get her tissue, and she also had a EGFR mutation. So it allows us to do things that we probably wouldn't have done before. Here's another example. This is a nodule right next to emphysematous bulla, right next to the aortic arch. I told my radiology colleagues, who's normally very brave, and he turned it down. So I said, okay, we'll try it. So once again, in a critical place with very critical structures, this gives us infinite precision and stability that we can again go quite deep into the lesion and access this area. But there are some nuances with the system, which I'll just show in a minute. So again, we think we're at the target. So we then basically deploy our system. But actually, when you do a cone beam CT scan, this just raises the problems of two-dimensional imaging compared to three-dimensional imaging. So you think you're at the right spot if you just had 2D imaging, but actually when you use the histogram, you realize you're slightly anterior to the lesion. So this allows us to, again, with quite great precision, just make a very small maneuver where we're going to move from the anterior position posteriorly. Now we're aligned. We don't actually bother doing another cone beam CT normally, but we throw a radial ultrasound in. If the radial ultrasound gives a signal, which it does there, we know we're in the right spot. But in this particular study we were doing, we had to show tool in lesion. So just to prove to everyone, this is the tool in the lesion, and we biopsied this, and this was a squamous cell carcinoma. Patient went on to have a resection. So again, it just shows you the elegance. Look at the curve of that robotic catheter. I mean, these are curves that we could not manage with a normal bronchoscope. We can even biopsy things which are touching the heart. You can see that nodule is touching the right ventricle of the heart. And actually with the precision, you can direct the needle and your biopsy tools quite elegantly. So I've got to the target. I've got a good radial ultrasound signal, so I know where I'm in the right position. But with the cone beam CT scan, I can point my needle away from the heart, but still be in the lesion, and therefore take multiple biopsies without any concern. So here's the cone beam CT. This system allows us to mark the nodule. So we've got this, what we call fused fluoroscopy. We've got the overlay together, and then we can do multiple biopsies right next to the heart without even bothering. And this particular patient had a carcinoid tumor, which was subsequently resected. So this is some of the very early work that's been done. And you can see now, just to put this all into context, most of the clinical studies show that even with the best proceduralists, if the nodule is less than 20 millimeters in size, the success rate for the navigation bronchoscopy was miserable. It was 65%. So just a little bit better than tossing a coin. But now you can see with the robotic systems, the yield and sensitivities are now approaching 80%. But I'll show you how we can take that even further. Interestingly, also, the pneumothorax rate is very low compared to CT-guided biopsies. And here's this, we did a study, because when you do a study and look at yield, the problem is you're dependent on having a good cytologist, the right biopsy tool. So there are lots of confounders. So we did a study where you forget about those confounders and you just show whether your tool is in the lesion. So does your system take you to where it should do, and are you at the right spot? And you can see in 200 patients, 222 nodules, we got to all of them apart from one. And the one where we couldn't actually access it, basically it was the sixth case we did. Now, just for a little bit of context, we named our robot OB1, and on that day when he was malfunctioning, it was doing this. I wanted to rename it Louis, but we stuck with OB1, and actually you can see that in 92% of cases we were in the inner third of the nodule, so center strike effectively. And I'll show you our results. And basically, what we did is we were able to biopsy anything. We were able to biopsy lesions which were mixed density, solid, with a bronchosign, without a bronchosign. In fact, only 26% of the nodules had a bronchosign, meaning an obvious airway leading into the nodule. The vast majority didn't, and it didn't really matter. And this is some of our data. And look at the number now. The median size of the nodules we sampled was 13 millimeters. And this was our first 100 cases. We've now done about close to 700 cases. And now we consistently do nodules about 5 millimeters in size. And I'll share a little bit of that later on. So with nodules that small, you can see that procedure time also was long to start with, but gets better. Our average time was 59 minutes when we first started, the first 10 subjects. If you look at the last 10 subjects from this quota, it was 35 minutes. And now we can more or less do a procedure. It's a single nodule, it'll take us 20 minutes, and then add on another 10 to 15 minutes for each additional nodule. So we looked at those 200 patients which had participated. We looked at their outcomes, and 148 of those patients had a specific diagnosis of malignancy. 22 of them had a specific benign diagnosis, by which I mean granuloma or amyloid or something very specific which you can say. So if they had atypical cells or indeterminate stuff, then we wouldn't actually call it a diagnostic, and we call it non-diagnostic. And if you follow these patients up, you can see that some of those non-diagnostic ones turned out to be malignant. So there is a false negative rate there. And if you look at that data, our diagnostic accuracy is 92.9%. Our sensitivity is 95.5%. And the cancer prevalence in that group was around 78%. So way better than any technology we had up until this point. Adverse events, well, we had one event where we think one subject had either a suspected air embolism or a severe watershed infarct, we're not sure which, but otherwise it's a very low risk procedure. No real bleeding events. Now, even though a lot of those nodules were right at the edge of the lung, you can see we only had one pneumothorax in 200 patients, which is completely different from CT guided biopsy, where the rate is around, varying from center to center, from 25 to 40%. Now, the beauty of this system is I can do bilateral nodules. CT radiologists can only do one nodule. They can only do one side. I can do 3 nodules. I can do bilateral nodules. We've now done some patients where we've done 4 nodules in one procedure. And interestingly, as we do this, we'd find out in this particular patient, the left upper lobe nodule was adenocarcinoma, non-mucinous. The left lower lobe nodule was a mucinous adenocarcinoma with a different genetics. And the one on the right upper lobe was a granulomatous nodule. So it does make a difference to actually sample these nodules. Don't call them all metastases or synchronous cancers. We talked about cryobiopsies earlier this evening, and the other beauty of this technology is we can very easily get very good samples. It's very simple. We basically park the robot to where we want to. We then just put a cryoprobe in, freeze, and then we pull out the cryoprobe and get very elegant samples. That's basically, we freeze for a few seconds and we get the sample excised. And again, you can see on the left is a CT guided biopsy. In the middle is a forceps biopsy. On the right is a cryobiopsy. Who's the winner? Pretty obvious to all of you. You don't need data for that. And the other thing about it is we can stage and diagnose the patients at the same time. But in the interest of time, I'll move on. This is a really extreme case. I mean, you can. I would have never have dreamt of doing this. But again, you can see with the robot, we've got to the nodule, and this another patient had an adenocarcinoma of the lung. Now, we can also help our surgical colleagues. So this day and age, if our surgeons do a lobectomy or a tumor like that, they get abuse all week. They should be doing segmental resections. They should be preserving the tissue. So what we tend to do is help them. So we stain some platinum coils with indigo carmine, and then we leave these fiducial markers when we biopsy these nodules. So that when the surgeon goes there, this mark will both fluoresce and it's also radio visible. and he should then be able to do a segmental resection rather than doing a lobectomy. So it helps us all work together as a team. That's the fiduciary. It looks like a very tiny marker. So now, just to touch on the subject you wanted me to talk on, but I felt it was out of context without giving the first bit, it's robotic ablation. Now, this is a patient who had a non-small cell lung cancer. She was treated with chemoradiotherapy, and 18 months later, you can see a little spot developing in the middle of her radiation field. And if you look at the PET scan, it is hot. So this is very, very likely to be a recurrence. So what we did is we did a robotic procedure on her, but in this case, what we have done is we've done biopsy and ablation all in one sitting. So we went to this very small nodule. You can see the radial ultrasound signal. We're in the nodule. We've biopsied it. And then at the same procedure, I'm putting in a microwave catheter into this nodule. This is the microwave antenna catheter going in. And then I will reset. So basically what we do is we place that in there. Although we do have cytology, but we don't have a pathologist there. We have silly me looking at this thing, saying, oh yeah, that looks like cancer, we'll move on and ablate the lesion. So we'd call it digipath rather than ROSE. And we also have to plan these ablations very accurately. So we look at where the nodule is, so we segment the nodule, we segment a margin of around 5 millimeters around it, we mark our microwave catheter, and then on the system we can actually create an estimation of the ablation. And therefore we should be able to make sure that we've covered the whole of the nodule. So it doesn't really project very well, but there's a green margin all the way around there. So once you get the ablation zone, it should all be green. And if there's any red areas, it means that you're not covering that area. So once we're confident that I've got the whole ablations area mapped out, I will then go ahead, and what we next do is to withdraw the robotic catheter because we have to expose the whole length of the microwave probe in order to deliver the energy appropriately. So I'm happy with the mapping. So I'll then move on to the next phase, which is essentially withdrawing the catheter. So I'm now withdrawing the robotic catheter. I've got 45 millimeters of it exposed, and it takes 3 minutes. I basically ablate that lesion in 3 minutes over a breath hold. So a very quick procedure. So the whole procedure from biopsy through to ablation took me 32 minutes. Here's the immediately post ablation CT scan. You can see we've ablated that area, and then I can show you the follow-up. This is day 1, that's at 3 months, and then it's at day 6 months. So essentially you make it a lot worse because you made it angry and ablated, and then it kind of scars down and shrinks down. And just to get your eye into it, I'll show you a few more cases. So there's a nodule on the bottom one. There's one on the top. You see, although the nodules are small, you initially, following ablation, get a big scar, and then over time it shrinks. And here's another one you can see. And you can see in each case it kind of is greatest initially and then starts shrinking. It's at the greatest point initially, and then sequentially it starts to shrink. But we can also hit pleural regions. You can see that bottom left-hand corner is very close to the pleura, right next to the kind of nerve roots, but yet we can adequately ablate it. So what we see when we look at the data is you've increased the size of the nodule, and then you basically follow it up and it should start getting small. If there is any areas where you can see a bit of growth, then you know that that might be vulnerable. So you may want to biopsy it, or you may just want to see it. So we've now done about 32 cases, but I just showed you the first 19 cases we've had. And you can see they were all kind of professional smokers. Most of them were solid nodules, so they weren't indolent cancers, they were proper cancers. And 42% were subsolid, so they were more the adenocarcinoma spectrum. Now, just to put this into context, if my radiologist do a transthoracic ablation, that patient is in hospital for about a week. They've also got a patient administered anesthesia. They've got a morphine pump attached to them, so they can't go home. And they've also got a very high rate of pneumothorax. My patients stay in for a day and they go home next morning. And then you stay in for a day because we're being cautious at the moment. And you can see these are the number of quality of life indices and the pain scores and things like that, and it's virtually zero. No experience of pain, even with subpleural procedures on the whole. So the adverse event rate of transthoracic ablation is on the left. So this is a meta-analysis of almost 10,000 cases. You can see death, pneumothorax rate between 25 and 40%, pleural effusions, air embolism, bronchopleural fistula, infection. Post-ablation syndrome is where they get fevers, sweats, infection. They're quite unwell and quite often need antibiotic treatment in hospital for a while. But you can see in our group, it's relatively mild. We did have one death, but I think that death was basically was a patient with COPD. He had an exacerbation about 10 days after his procedure, went to his local hospital. The registrar on call saw that this was a patient with a cancer, did not give him NIV, put him on a morphine pump. So, I mean, we have to count that death as an event related to our procedure, but I think that was basically euthanasia in disguise. So, can you spot the nodule? I've made a big circle around it because even I couldn't see it. 4 millimeters in size. If you asked me 3 years ago that, can you biopsy that? I'd say, what are you smoking? So this is what I did last week. So we biopsied it, and we ablated it in the same sitting. And I got the pathology on Thursday, colorectal metastases. So I just wanted to show that to show you the precision of that technology. And if you think we were just lucky there, this is another patient, 6 millimeter nodule in the right lower lobe, biopsy proven. Again, about half of our 32 patients, we have done a biopsy and ablation in the same sitting. In half of them, we've done a biopsy, we waited for the results, and then done an ablation. We're obviously going to look to see if they behave differently. But on the whole, I haven't seen a difference. But you can biopsy and ablate in the same sitting, no waiting list. The patients don't have to come back for treatment. It's all done in one procedure. And then just give you a little bit of what I think is probably the future and maybe a bit rocket scientist. So this, again, you do the procedure. We are choosing patients who have 2 nodules. We treat one of them. They're both proven to be cancer. We treat one of the nodules, and we do not treat the other nodules. So we use irreversible electroporation. So the robotic bit of this procedure is very similar. You go to the lesion, and once we're the lesion, we have this rather special device, which I'll show you very shortly, which will come through on the video. So this is basically going to the nodule. Once we're at the correct area, I introduce this special needle, which is quite a clever electrode. So the needle goes into the nodule. It senses the tumor. So we measure the impedance of the tumor. So it basically tells me normal, normal, normal. And then, this is tumor tissue. So once I hit tumor tissue, I would then advance a different needle. This is just to verify that we're in the nodule itself, the kind of truth data that we like. But going back to the first bit of the procedure, so when we're inserting the needle, it's sensing it. You sense the change in impedance. Once we sense the change in impedance, we put another core needle over it. So there's another core needle that comes over that. And then we pulse. See, here it is, just getting it all lined up. And then once we're ready, the sharp needle goes in first, which is the sensing needle. Then we advance a core needle over it. And basically, we want to position it so that the 2 endpoints of the 2 different needles are at either end of the tumor. And once they're at either end of the tumor, we pulse 3,000 volts of energy through there 90 times. So between the 2 points of the needle, we'll then pulse the energy. And effectively, what we're doing is we're destroying the cell, but not denaturing the cell. You know, when you cut it out, it's out. When you give radiotherapy, it's destroyed. When you microwave it, it's destroyed. But this way, you're not destroying the protein structure. And we're hoping that it will go and immunize the patients against their own cancer. So there's a patient. You can see the blue line is the one I've treated. The white one is the one I haven't treated. This is the kind of zoom up of it. And this is the pathology. So firstly, it's to prove that we've completely destroyed it. So the uppermost area is actually destroyed tumor. Sorry, so the very uppermost area is the latent tumor. This is the residual tumor. We want to look at different patient, and basically we'll be looking at to see whether we're getting lymphocyte proliferation. We've got single cell sequencing and a whole other studies ongoing to see whether we can immunize the patients against their own cancer. And I'll stop there. Thank you.